Well, welcome everyone. I'm Mary Funseth, and we welcome you to session 4 of our structured collaborative for chronic disease structured collaborative session 4 for medical nutrition therapy for chronic kidney disease. Sorry about that. I had just like a little pause there in my thinking. So today's objectives are to define medical nutrition therapy. We're going to describe nutritional concerns associated with chronic kidney disease. And we're going to identify appropriate nutrition interventions and therapies to prevent and treat nutritional concerns. So today, just a couple of housekeeping things. I'll let you know right off the bat that we are going to be taking questions a little differently today. We're going to have you place your questions in the chat, and we will then answer those questions at the end of the presentation today. And Jerry is on chat, so she will be paying attention. So if you have any questions or concerns during the event today, please don't hesitate to reach out to Jerry through the chat. So today we have a poll. I will ask Jenna to go ahead and launch the poll. So the question is, healthy dietary patterns are key in treating which of the following conditions? Diabetes, CKD, hypertension, obesity, or all of the above? So give that just a moment. Okay, there you are. We have all of the above.
Awesome.
Next, what I want to do is, we'll stop that sharing for a moment of the poll. And we today would like to introduce you to Janelle. She will be presenting for us on medical nutrition and therapy. I'll have Janelle give you a little bit of her background before she gets started, and I'll turn it over to Janelle.
Thanks, Mary. Appreciate the invitation to participate in the collaborative here because I've been a dietitian in the nephrology area for 33 plus years, and you know, the use of medical nutrition therapy in this patient population can make such a difference, and it's such a rewarding thing if you can get to these patients early and help them with this. So we'll go to the next slide so we can start with what medical nutrition therapy is all about. Medical nutrition therapy is something that we like to call this type of interaction with the patient rather than diet. Diet is probably the thing that causes more angst than anything else in a care plan for a patient. And we want to offer them something less intimidating. And there actually has been some legislation that was enacted back in 2000 that defined this for us. And specifically, medical nutrition therapy is a nutritional diagnostic therapy and counseling services for the purposes of disease management, and it is furnished by a registered dietitian. And this is very important with respect to reimbursement, which I'll get into in a little bit. And if you notice, there are a couple of references at the bottom that give a lot more detail about the Medical Nutrition Therapy Act. But specifically, the thing I want to highlight here is that it's a supportive process to set priorities, establish goals, and create individualized action plans which acknowledge and foster responsibility for self-care. And I want to highlight that because what we do as dietitians with medical nutrition therapy is take this to the patient level, individualize everything so it's doable for them so that they can do the self-care that's necessary to manage their medical condition. And we know that with patients who have CKD, if they do follow medical nutrition therapy, they do show less decline of GFR, have better outcomes. And we also have studies that show, and specifically reference to, that the earlier we can deliver this medical nutrition therapy and help patients with this, the more impact that it's going to have. Next slide, please. As far as reimbursement, this is where the MNT Act came into being. And basically, it requires a physician referral. It is a Medicare-based program, and they specify that it has to be provided, as I said, by a dietitian, but we also have to be enrolled in the Medicare program. So that's one caveat. The reimbursement will flow when their GFR is 13 to 50. So they've already have established CKD, and they will actually cover 2 to 3 hours per year, which is pretty good. And if the patient has a significant change in their medical status and the physician orders it again, we can even provide more than that. It can be something reimbursed by Medicaid, but certainly those are state administered programs, so it can vary by state, and private insurance will often cover because they follow suit with Medicare so often, but again, that can vary. So if you're looking to help establish a CKD practice, there is this downloadable on the right of the slide that is produced by the American Kidney Fund, and it's basically a 3-page handout for individuals who would like to introduce MNT into their practice. And so basically it talks about, you can go to the website, download it, but it talks about what dietitians and medical nutrition therapy can do for patients, how to refer, and how to find a dietitian in your area that you can collaborate with to provide this MNT. Next slide, please. I do want to talk a little bit about the MNT and what is specifically provided, because that's a big part of it. We do use evidence-based guidelines, and there have been evidence-based guidelines for many decades, but the first formalization of them occurred in 2000. And historically, those guidelines have focused on nutrient limits. So you've probably heard a patient should have so much protein, sodium, potassium, phosphorus in their diet. And so we would focus on those individual nutrients, but unfortunately, sometimes that didn't provide the healthiest diet for the patient. You know, prescriptive, we were able to satisfy, but maybe not an overall healthy, balanced diet. And because of this, we found that the kidney diet was always in direct conflict with the diabetic and or cardiovascular diet recommendations. So for example, a diabetic may have relied heavily on lots of vegetables in their diet to control their carbohydrate intake, but then when they were talked to their CKD dietitian, they would say, oh, we got to cut back on those vegetables. And so we had a direct conflict there and would have to help the patient prioritize which diet they should follow. And that just made it very confusing for all. Fortunately, we gathered more evidence. The new recommendations came out last year. So there's a 2020 publication listed there in reference to that gets all of the nitty gritty there. But specifically, the focus is now on healthful eating patterns. So we're trying to avoiding entire food groups, which we used to before, because we found that that's no longer warranted and can actually be harmful to the patient, because we're finding that total diet quality is what's most effective to slow any kind of disease progression and promote prevention of those disease processes. And so the good news is the kidney diet is now very consistent with diabetic diet and also eating patterns for those to promote cardiovascular fitness. So this is so much easier for the patients and providers as well. Next slide, please. So MNT is something that is difficult for patients because it will change with each stage of chronic kidney disease. And so I've broken today's discussion down into the various stages. And I think this is helpful for us to wrap our heads around it a little bit better. But we also try to discuss this with patients early on. And in my practice, we actually had a specific educational material called Expect Changes in Your Treatment as Your Kidney Function Changes, because these things are going to be progressing as we go along. So next slide, please. Basically, with each stage, we find that there's a layering of diet recommendations. So I kind of pulled together this table as a visual, because I'm more of a visual person myself, to show what things are addressed in those guidelines. And as we revisit this table throughout the presentation, you'll see how things are going to be layered for individual patients. Next slide, please. So specifically in those earliest stages where we're hoping to catch up with patients, they're at risk and in stage 1, or we've noticed some definite changes and they're progressing to stage 2, we do know it's critical to manage all their comorbidities to protect their kidney function. So if they're diabetic, we want to make sure we optimize their glucose control. If they have cardiovascular disease concerns or are hypertensive, we want to make sure we manage that. And we also look at their weight, because we're finding that obesity in and of itself is a risk factor for chronic kidney disease. Even when you control for diabetes and blood pressure, we're finding that this obesity or high BMI will cause difficulties. So if the patient is above an ideal body weight, we will help them with weight loss. We know that we need to start tweaking the diet a little bit. So we're going to moderate their protein intake. Specifically, we'll introduce plant-based proteins, and I'll go into that in more detail. And we're going to try to control their sodium intake. Next, please. So specifically for diabetes, as we mentioned, we want to optimize their glycemic control. And the reason for this is that we know that we can control albuminuria and also hopefully prevent kidney damage if we can do this. There are some excellent guidelines that came out last year, again in 2020, and those are referenced here for more details. But basically, you can imagine the guidance is going to be proper medication management and lifestyle management. So specifically for medical nutrition therapy, we're going to work with patients regarding the amount of carbohydrates, the type of carbohydrates in their diet to optimize their control. And we're going to work really hard on encouraging physical activity as tolerated. Next, please. Hypertension, of course, is one of the major comorbidities. So we're going to work with patients to achieve their goal blood pressure. And last week, Dr. Sigal talked about what goal blood pressure was and things to consider in that regard. So I won't go into that. But again, a key guidance is going to be what medications do they need? How should we adjust them? And lifestyle modification. And it's the lifestyle modification where dietitians can be very helpful, I think, because we're going to work with them to get them on an appropriate eating plan to help manage their blood pressure. And the thing that's been the most successful diet in this regard since the 1990s has been what we call the dietary approaches to stop hypertension, or the DASH diet. And specifically, this is a diet that's lower in sodium and fat, but it's also higher in potassium, magnesium, calcium, fiber, and antioxidants, all things that do help lower blood pressure. And we can't forget about our regular physical activity as tolerated. So we'll work with them on that. And again, you see a reference there for recommendations for management of hypertension in the chronic kidney disease population. Next. Now, with respect to obesity, as I mentioned, we do have to address this, not only because it's an independent risk factor, but also if this individual were to progress in their chronic kidney disease to end stage and require treatment options such as a transplant, we need to have them at a more healthy BMI. So we do have to keep these things in mind for the patient. We're going to promote as gradual of a weight loss as we can, because rapid weight loss is the equivalent of lean body mass loss rather than losing body fat. So we do have to monitor this closely. And again, we're introducing the healthy eating patterns so that they get all their goals while they're focusing on their weight loss. And we're also going to work with them on physical activity. And sometimes this is trickier in this patient population because there are physical limitations, but we do work with our medical providers and we encourage it because we need to prevent muscle catabolism in this patient population. So when we think along the course of someone who's at risk for chronic kidney disease, we're going to individualize their therapy because we know that promotes the most success. But we also have in the back of our minds, not only do we have to get them to a healthy BMI for transplant if that's necessary, but we also know that malnutrition is something that's going to show up in the later stages of chronic kidney disease. So we have to balance those two. And again, we'll get into that in a little bit more. So since we have so many things going on with weight management, it really requires the frequent monitoring to keep patients motivated, on track, and avoid some of these complications. Next slide. So I just want to put a little bit of a point on exercise and CKD because I feel like this is just so vital in their care plan. And it's important because we know with CKD, sometimes patients don't necessarily feel like exercising, think that they should exercise, but they really should. And there's been research done in this regard, and more studies are ongoing. But we know that those with CKD who do not exercise, they're going to have significant reduction in their physical functioning abilities and have a poor health quality of life. So we want to prevent that. We know that it improves health outcomes when we look at things such as cardiovascular disease. And we have even seen some evidence that it may slow the rate of CKD progression. There's more studies that need to be done to verify this, but it is looking promising. Next slide, please. It's so important that the international guidelines started to address this back in 2012. And here's their specific recommendation. They believe that people with CKD should undertake physical activity compatible with their cardiovascular health and tolerance, and they should aim for at least 30 minutes 5 times per week. So it's consistent with general recommendations, but this is the first time that I saw it mentioned as a priority for these patients. So we are going to encourage regular physical activity as dietitians, even though we can't give a lot of specifics like a physical therapist could, but we can maybe hold them more accountable to it and show them how this is all interrelated. So we make it very goal-oriented and help them set up SMART goals, because if they're not specific, measurable, achievable, realistic, and in a time frame that's reasonable, I find in my practice it's never going to happen. So an example that we give here, some patients just feel like they can't do anything. They don't realize that they can walk up and down their driveway to the mailbox. That's activity, and it's routine activity. And so we try to guide them with those recommendations, setting up goals that are reasonable for them and helping them progress their goals as they go along. Next slide. So what is this recommended dietary pattern that's somewhat new in the CKD realm? Basically, it's any eating pattern that's going to incorporate more plant-based protein sources. And this is very important for CKD because we find that protein sources from vegetables have less hemofiltration response and are easier on the kidneys. And we also know that over time, and its interaction with the gut microbiome, we do see decrease in uremic toxins building up. We know that by increasing fruits and vegetables, we can improve their acid-base balance, which can slow progression. We know that it has to be limited in sodium because that will improve their blood pressure and fluid balance. And we know that overarching, we want them to consume as fresh of foods as they can versus the packaged and ultra-processed foods. And this is just a way to avoid the additives that may be really high in sodium or phosphorus, for example, which are things that we're concerned about in this patient population. And common examples of these eating patterns are the Mediterranean diet, a variety of vegetarian diets, and the DASH diet that we've already described for hypertension management. And again, these eating patterns are very detailed in the new nutrition guideline recommendations that are referenced at the bottom there. Next, please, Mary. So if you remember, in addition to managing comorbidities, we're worried about protein in their diet. And we worry about the amount of protein in their diet because studies have shown that lower protein diets slow progression. But we do have to have MNT involved here because, go back please, Mary. We have to have MNT involved because when protein is restricted, you just can't tell someone to stop eating protein sources because we have to have adequate calories and balance here to prevent malnutrition. So we do worry about the amount, but want to guide them in that regard. And we also know that the type of protein is extremely important, and that's new in the realm of CKD diet. We've learned that compared to animal protein, vegetable-based proteins have a lot of benefits, such as decreasing inflammation, reducing the metabolic acidosis and hyperphosphatemia. As we mentioned, fewer uremic toxins are produced, and it improves the gut microbiome. So all of these things are very protective of kidneys. So we want to look at the type of protein. Next slide, please. The more specifics, however, oops, I'm sorry, back up. There you go. Thanks, Mary. Very specifically to quantities of protein, this is addressed. And again, it's something that we can help patients with in the earlier stages because we want to avoid excessive protein intake. We want to start directing them toward a more controlled protein intake in this regard. And sometimes just raising the awareness is all that it takes. But we do want to try to direct them toward what their basic needs are or what the recommended daily allowance is, which is 0.8 grams per kilogram. If they progress to stages 3 through 5, then we find we have to nail that down a little bit more specifically and drop the overall protein intake to 0.55 to 0.6 grams per kilogram per day. That would be for someone who does not have diabetes. We do allow a little bit more protein in the diet, kind of bridging to that basic RDA for diabetics, because we find that a little bit more protein in their diet may help with their glycemic control. So we do allow them a little bit more, but this is why low protein diets are kind of the hallmark of CKD diets. We just know it helps prevent progression here. We know that we have to probably slowly adjust to ensure success because this is a big change. When I see patients, sometimes they're eating 2 to 3 times the amount of protein that they should be. So it's really hard. So sometimes we raise the awareness and sometimes we are very specific to replace some of that animal protein with more plant-based proteins. And it's kind of a sneaky way to get in the benefits of the plant-based protein, but eating a plate of protein, plant protein foods is more satisfying than maybe 2 to 3 ounces of meat. So it's just ways to help them control their intake. Next slide, please. I'm not going to spend a lot of time on the low sodium diet because I think that's probably pretty familiar to folks because it's been around forever, of course. Specifically, the goal recommendations from the 2020 guidelines say that less than 2.3 grams of sodium per day per patient is what's recommended. There are some interesting caveats, though, with the CKD patients that we have to keep in mind when we're guiding them. We have to have them avoid the use of salt substitutes because most of those contain potassium chloride. And we know that any food that's marketed to be low in sodium probably contains that potassium chloride and maybe even phosphate additives, which are not good. And we'll talk about that a little bit more. We know that there are medications like the ACE inhibitors that Dr. Sabel talked about last week. They're more effective if a patient can control their sodium intake and they have less proteinuria. So these are all very important reasons for a potential CKD patient to be very mindful of their sodium. So it's just not limited to blood pressure in this group. And basically for counseling, we just try to help them prepare their foods with flavor when they don't use the salt and salt substitutes that normal people could possibly use. Next, please. So we're going to march forward to stages 3A and 3B. Next slide, please. And you can see from our diagram that we're going to be bumping out the diet a little bit more. And this is just another reason that the earlier we can refer patients, the better. So we can start establishing some of these changes more gradually with the patient rather than having to hit it all at once. You can see potassium and phosphorus are the two things that start to get a little bit more focused in these stages. And potassium, particularly in stage 3B, because once we see the GFR drop below 45, they're going to be more likely to have higher potassium levels because they're not going to be clearing as much. Next slide, please. So specifically, we're going to do all the same things we did before, but we're going to put a more fine point on monitoring things like serum potassium levels, especially if these patients are on medications like the ACE or ARBs that we know will increase potassium. Next, please. Next. Okay, thank you. So specific to potassium, as you can imagine, our goal is to keep it in goal range of 3.6 to 5.2. Again, there are some things that we do have to stay very focused on with the CKD population, and that's just that impact of those medications. And they can be impactful when they're first started, when doses are adjusted. So it's the frequent monitoring of potassium that's very important so that we can maybe offer some potential solutions. One solution is to withhold or reduce the dose of these medications, but nobody really wants to do that because they are so helpful in slowing progression and cardioprotective. So we don't want to do that. We can limit potassium in their diet, so we can focus on things like high potassium fruits and vegetables. But again, we don't want to hit that too hard because we want to have that healthful eating pattern. So the new tool that we have is use of potassium lowering medications. So these new potassium binders, as a lot of people refer to them, can be utilized in this patient population so that we can hopefully continue with the protective medications and the healthful diet. Next paragraph. As dietitians, we're going to adjust their diet to include the lower potassium fruits, vegetables, and plant-based protein. But we do have to make sure that we stress portion sizes of all foods when we start talking about potassium. And that's basically because when we talk about lower potassium foods, apple is the best example that I give to my patients. Apples in general at a reasonable portion are low in potassium. And that would be a small apple that they could hold in the palm of their hand. If they eat a huge apple that's almost a pound, like I see at my local supermarket, that's probably closer to 3, if not 4 fruit servings. And so you can imagine in their mind, they ate just an apple, but they actually ate maybe 3 or 4 fruit servings in that one sitting. So we do talk about portion size a lot. And we do teach them how they can prepare their foods to have less potassium. So if they take potatoes, peel and boil them, then they're a lot lower in potassium for their diet. And also this works with things like the plant-based proteins, the beans and the lentils. So we teach them how to do that. And we also teach them how to interpret food labels. Fortunately, we finally have potassium listed on our food labels, so we can help patients decide between foods as far as what the appropriate potassium content should be. Next, please. Phosphorus, we're going to try to again maintain serum phosphorus in goal range of 2.5 to 4.5. Diet modification is definitely first line therapy. For this patient population in these earlier stages of CKD, it usually isn't a big problem because if they're limiting their protein intake, they're going to be limiting their phosphorus intake because the largest amount of phosphorus naturally occurring in our foods comes from the dairy and meat in most people's diets. And we also take into consideration something called bioavailability of phosphorus. Phosphorus in foods, plant-based foods, are bound by phytase, and the human gut does not have the phytase or the enzyme to break that apart, and so they don't absorb very much. So that's why we're finding that we can really let patients eat more of these whole grains and healthful foods, because if it's from the plant, only 10 to 30% of that phosphorus that it contains is ever going to be absorbed. Where if you go toward the more animal-derived foods, you're going to see a 40 to 60% absorption. But the earliest stage is what we do is really try to get patients away from those phosphate salts or additives. We call them inorganic phosphates because they're 80 to 100% absorbed. They're found in processed convenience, fast foods, bottled beverages, anything in a package could potentially have phosphorus added because it's either a preservative, flavor enhancer, helps with the texture, etc. So this would be the first line therapy, is avoiding these whenever possible. Next, please. To monitor how they do over time, we check their serum levels and just continue to address that healthy eating pattern, because if it is more plant-based and non-packaged foods, it's just going to have a lot less phosphorus that's absorbable to begin with. And then when they do eat packaged foods, help them read the labels so that they can avoid those phosphate additives. Next, please. Moving on to stages 4 through 5, this would be the non-dialysis population in stage 5. Next paragraph, or I'm sorry, next slide. Here's the table's kind of rounded out. You can see that once we get to stage 4 and 5, it's kind of the full court press for their diet, and we have to really watch everything. Next, please. In addition to managing those comorbidities like we have all along, we're still going to pay attention to all that and help the patient dovetail that all in, but we do need to take special consideration of their body weight, because by time we get them to this stage, we might see some significant weight loss, and unfortunately, it's going to likely be lean muscle mass. So we got to really work hard on that and strike a balance between their protein goals, because we don't want them to lose any of that muscle mass. And if they're too aggressive with their protein reduction, that can impact us as well. We get a little finer tune on the sodium aspect sometimes here because of potential for edema. And we're just monitoring all levels at this point very frequently because we probably need to keep adjusting the diet. And the new kid on the block here is going to be the signs and symptoms of CKD, the nausea, the vomiting, fatigue, and edema. All of these things can have an impact on their ability to eat and what their diet should look like. Next, please. We talked a little bit about malnutrition, and this can either be the protein energy malnutrition that comes just from not eating enough protein and calories, but we also have something unique to CKD called protein energy wasting, or PEW, which is associated with more of a wasting phenomenon. So they may be eating reasonably well, but there's something about the uremia that is causing them to have more tendency to waste their muscle mass. So that's the hallmarks that we look for. And we know that as their GFR drops below 60, they're just going to stop eating as much. They're going to have less calorie intake, less protein intake. And we need to really have that ongoing assessment with this patient population to look at all these key markers and try to prevent. And it's really better to prevent the malnutrition than try to treat it. But prevention is kind of hard in this patient population because many of them have tried their whole adult lives to lose weight, and they never were extremely successful. And now they are without even trying. So they're not really quick to buy into, maybe a little more calories, nutritional supplements, things that we want to emphasize, but it's very important to prevent that malnutrition. Next. I do want to throw in here, there are special considerations for diabetic patients when we get in these later stages, and primarily it's the concern for hypoglycemia in this group. And it's related to multiple factors, I should say. First of all, the decreased food intake that they may have if they're experiencing a little bit of nausea and vomiting. They're just going to be eating less, but they don't change their medications to manage their glycemia in harmony with that. So we see hypoglycemia result from that. They have reduced clearance of their meds, so maybe they're still eating fairly decently, but those meds are just hanging around a lot longer than they used to. And so that can lower their blood glucose levels, and also impaired gluconeogenesis. Patients don't realize that their kidneys play a role in that backup behind the scenes production of glucose in their bodies, and they lose that ability. So we do have to watch them very closely. And so when they do start having hypoglycemia, we work collaboratively with the team. We adjust medications, we adjust diet if we can, but we also have to teach them new ways to treat their hypoglycemia because they're going to be very tempted to take orange juice because that's how they were trained eons ago. And it's a knee-jerk reaction, but orange juice is very high in potassium and not good for them to use at this stage when they're likely to be hyperkalemic. Next. So to summarize, next, I'd just like to bring together the fact that our patients, they are very complex, have a lot going on, and we can't be with them for 24/7. So really how we counsel these patients and what they can achieve on their own is really going to be the secret to their success. And so we have to keep in mind that we've learned it's not an all or nothing proposition. So especially if we can get to them early, we can head them in the right direction and do a stepwise fashion to hopefully prevent. And if not prevent, we can slow the progression of their disease. And when we look at adherence, especially to complicated diets, we really need to have this flexibility with the patient to sustain their changes. We do know the best diet is the one the patient will follow. So this is where the shared decision-making comes in. We have to sit down with our patients. These are our goals. How can we meet in the middle to make sure that they're able to achieve those goals? And really focus on those self-management strategies. And that's a lot of it because I find a lot of my patients, when they come to me, they already have a sense that their eating patterns are important and maybe they found a bunch of lists of things that they have to avoid, but how does that work for them and how do they self-manage these things? So that's very important. And I just have on the next slide one more comment about self-management. Next slide, please. Thank you. Because again, there's caveats with that with CKD because we know self-management in any disease condition is the best way to go. But our patients, unfortunately, have them all sometimes. They have diabetes, they have hypertension, they're overweight, high cholesterol, and now we pile on with CKD. So helping them intertwine all of these complex therapies, both diet and medication, to help them balance everything that they need to. And realize that in these later stages, apathy is a huge issue. And in part, that's because, maybe we caught them in stage 2 and 3, and boy, they made a lot of great changes. They started becoming physically active. They made all the changes in their diet that were recommended, but yet their disease progressed. So it's kind of like, why do I do all this? It's not getting me anywhere. So just reinforcing with them how far they've come, what there's yet to prevent, and work with them in that regard. So Mary, I'm ready for questions if there are any.
Thank you so much, Janelle. There's so much in there that I have learned new, and I hope that this has been helpful to others as well. At this time, before we get your question and answer those questions, we'd like all of you to chat in your name, and obviously we can see your name, but we'd like to have you chat your name along with what organization you're from, what's your position, and what state are you from. So if you can go ahead and start chatting that in now, and then we will take a look at what's already in the chat, and we will ask those questions of you, Janelle, in just a moment. We'll just give everybody an opportunity to introduce themselves that way. And then we're also going to ask you to open your mics to ask questions as well. But first, we'll get to those questions in the chat. So Jerry, would you like to read off the questions to Janelle, please?
I sure will. I'm sorry, I was just getting back to them. So I have two questions actually from Maria. The first one is, what are the recommendations for how frequent you see the patient with a GFR less than 30, but they're not on dialysis? Medicare pays 3 times, but what do you recommend?
Actually, I recommend that they see their dietitian quarterly at that point, just because there's so many moving parts and things can change from one day to the next. So it's nice if we can see them when they come in for that routine blood work so that we can address any changes, but also very importantly is to monitor them for malnutrition, because if they end up malnourished before they end up on dialysis or transplant, it is really, really, really hard for us to battle that at that point. And we want to optimize their transplant potential, and we want to certainly help with their quality of life and health outcomes with dialysis too.
And the next question then, and I'm going to pop it in the main chat too, is if a patient is going to have a preemptive transplant prior to dialysis, are there any different recommendations for diet that should be considered?
No, not any different, but more so the focus on the BMI, because every program's a little bit different, what their BMI should be to have a successful transplant. So we typically find out what the surgeons and transplant team are thinking, and we help guide the patient there. So we might lean on that recommendation a little harder than we might with someone who is not pursuing transplant, and certainly elderly patients who are more at risk for malnutrition.
Any other questions, Jerry, in the chat?
I am not seeing any in chat. So please, and also if people just want to ask their
Open
questions.
up your mics now, sure.
Yeah, they can just take themselves off mute. Oh, here's another one, sorry. Are there evidence-based practice that you need to see these patients regularly? Does nephrology clinics, do they have requirements by CMS to make dietitian referrals?
Right, so there aren't CMS mandates for dietitian follow-up as we have in dialysis, but this is something that's being tracked, because if you fill out a 27-28 out of patients for their dialysis therapy, they ask the question, was a dietitian involved in the patient care? So it's being recognized as something that we need to do. So yeah, the requirement isn't there. And so that's kind of why this has lagged a little bit in being addressed, because we don't have those requirements. It's the right thing to do, the best thing to do for the patient, in other words, but it isn't something. The only reinforcement we have of that in recent years is the MNT coverage in the Medicare population. They recognize CKD as something that really needs to be addressed.
We have another question. What are examples of plant-based proteins? And I am going to tag on to your question, Diane, with our protein powders okay? So like a plant-based protein powder to get enough of their protein.
Right. So examples of plant-based protein is trying to ease them from, what we consider a typical Western diet of beef and pork and the animal-based proteins, to the plant-based, which are more the seeds, the nuts, the lentils, the beans, trying to get them to consume those more frequently. And as far as supplements, we don't really distinguish a lot when that's involved. So we probably wouldn't be recommending protein supplements unless we see a concern for reduction in spontaneous protein intake in those later stages. And at that point, most of them are either dairy-based or plant-based, and either or works just fine if we think the patient needs that. But the thing that's truly most important is making sure they get enough calories. Sometimes the patients get so focused on their protein intake, and I would always follow up with my patients with a food record in a month, and they really got the protein point and sodium point. But when I looked at their total calories from the time I had assessed them to the changes, they were like 300, 400, 500 calories in deficit of what they should be. Even for those who need to lose weight, sometimes they undershot because they just cut those foods out of their diet and they didn't have the better balance that we need to do. So yeah, it's something to be mindful of.
And here's another question. From Diane, can you describe any healthcare equity issues with nutrition and chronic kidney disease?
Well, as far as healthcare equities, I worry about referral in general. I think we're just as subject as other areas of medicine where patients aren't getting referred and aren't being seen. Once we see them, some of the struggles come with, how can I get these fresh foods? How can I get affordable nutritional supplements? And those are things that we have to work very hard with the patient and collaborate with other team members like our social workers on how can we ease this burden for our patients.
I'm not seeing anything else in chat unless I'm missing it, but okay. I have another question for you, Janelle. Sure. This is something I feel that we run into quite often with the patients we work with. So we're talking about diet and trying to, things they should and shouldn't be eating. But then when we see because I'm sure you're seeing patients who are maybe in a senior housing or an assisted living, or even sometimes nursing homes, and it feels like everything you talked about, what they should and should do, becomes a real struggle when it's kind of, what do I want to call it? Cafeteria food. It's the bulk food that they have to purchase to make, to stay on budget, and it's full of sodium. It's not fresh. It's not, so what are your recommendations in those cases for those people?
Right. Well, you definitely have to collaborate with these facilities to help them because maybe they can make exceptions for individual patients. If this patient's at risk for hospitalization, that sort of thing, because they have too much sodium in their diet, sometimes that justifies the additional cost in my experience. And just helping them work through that, because this is just as overwhelming for them as it is for the patient. And so I find myself even, working with kids, calling the school nurse and talking with the teachers, and, all of that collaboration is so necessary so everyone understands the end point. The other thing that's interesting about that group, Jerry, is that they probably have itty bitty appetites because of maybe their age. And then that's also aggravated by their CKD. So they may not need to be on as restrictive of a diet because their overall intake is so poor. And sometimes we're making up those extra calories and protein with nutritional supplements, which are more controlled for those minerals, if that makes sense. So again, it just gets back to the individual and the circumstance that they're in.
I would simply add about the nursing home. I would definitely ask that those on the call today who will be taking this information back to their providers to ensure that your providers know that they can definitely get involved with the patient's diet for a person who lives in assisted living or nursing home. I am a past nursing home social worker, and first of all, I love the fact, Janelle, you brought up social workers, because yes, we can be helpful in helping find resources, but as a nursing home social worker, we can work with the provider and our dietitian in-house, as well as the kitchen staff, to ensure that the proper diet is served to that patient, and would meet the guidelines that you're discussing. They can adjust portion sizes, they can adjust food types, and it is part of a care plan. So sometimes we see providers back off on providing guidance within a patient's care in a nursing home because they have additional clinical staff around them at all times. But it is not unusual, and it is okay for that community provider to provide some guidance along, with what you said. So I appreciate that you brought that up, Jerry, and such. But I would really encourage everyone to take that back to the provider, knowing that they can do that and that it can be so helpful.
That's a great point, Mary, because I do think sometimes too, yeah, that does happen when they're in a controlled setting. We think they're getting what they need when maybe they aren't. Mm-hmm. I just wanted so Deb added a note here too from her experience with her father, is that he did not see a dietitian very often, and his mom struggled often knowing what to cook. And I think once patients get on dialysis, they probably do see a dietitian pretty regularly, but those pre-diet, and as you noted too, Janelle, if we're doing things with diet and exercise, we can maybe, hopefully prevent this. That's what we're trying to do. We're trying to prevent or, slow down the progression to dialysis. So I'm wondering too, is that something within clinical settings that they can reach out through the social worker, or just knowing that most clinics probably do not have a dietitian on staff?
Well, it's kind of a struggle, both from a dietitian standpoint and a social work standpoint, I think, in the CKD population, because we're not mandated to the degree that we are in dialysis. And oh boy, is that short-sighted.
Yes.
Yeah.
It just drives me crazy, to be honest, that we're not addressing this, because what the heck, if we can, halt progression in stage 2, we're not even going to get to some of these metabolic consequences, that are so burdensome to patients, both of added medication and diet parameters, So yeah, it's very frustrating when we can't get to patients. And it's the frequency of care and follow-up that I think makes this possible, both from the standpoint of them understanding complicated things, but the adjustments, what sounded good in the office today may not have worked out at home. So we got to rechange that plan, and work with the team to do that, whether it's a medication change, a diet change, home environment change. So the whole team really delivers medical nutrition therapy collaboratively. I mean, we deliver the bulk of it, but it's the team approach, I think, that pulls it off.
Thank you, Janelle. Go ahead and continue to chat in your questions. We will continue to answer those. We wanted to draw your attention to action planning. We have developed a plan of action for this week. I do not believe anyone here was on last week, so we're going to not discuss last week's action plan, but it can be available to you the reason why we put action plans within this structured collaborative is it's for an opportunity for you to consider trialing some things in between weeks. And for the weeks that you may not have attended, those action plans are available to you, and we can make them available to you whenever you need them for something to consider as a small test of change or just some simple checking within your system as you move forward, even after we're done with our structured collaborative. But this week we have, we would like you to consider reviewing your referral processes to a RDN for CKD and MNT. This is something that, you know, Janelle has already talked about. You know, the mandates are not there, but your health systems may already have some policies in place. If you find something that you're not certain is the best practice, that's a great opportunity for you to reach back to us, because then we can reach back to Janelle and Midwest Kidney Network and others to find out what would be best practice. And then hopefully we'll see you at the next session, and then you could share what you did find out, whether you like what you found or you didn't. This is a great opportunity to share with each other and learn from each other, and us to learn from you.
So Mary, sorry.
Go ahead.
I was just going to say, so Diane had asked, do nephrology offices and CKD clinics have access to renal dietitians? And then Maria did respond, I believe, Maria, this was in response to Diane's question, saying we do, but it's low utilization. I think this presentation was, then she goes on to say, this presentation was great. We really need to do a better job to prepare them for stage 5.
Mm-hmm.
So hopefully I captured that correctly, Maria. If you want to add anything, go ahead. You guys, anybody can certainly take themselves off mute and join in too. I want you to feel that only Janelle, Mary, and I can talk.
Yeah, actually, it'd be great if everyone would take themselves off, because I know that in the chat, you all talked about where you're from, but none of you said what your position is with your organization. We have just a couple minutes. If you wouldn't mind, Deb, what's your position?
Hi.
Hi.
Did you ask for Deb?
Yes.
Sorry, I'm employee health here at the hospital. So indirectly, I, monitor employees and how they're doing with things. And then I also, the personal experience, I just went through this all with my father, and I can see things that we struggled with.
Yeah.
And like I said in the chat, my mom, she would go, I don't know what to cook. And, and then she would say, we would remind my father, oh, you probably shouldn't have that. And then both of them would go, oh, just this one time. And my husband said, how many just this one times are there? Not to them, but and we talked about that to ourselves.
Right.
Every time my mom would say, oh, just let him have a little bit. Oh, just let him have a little. And, I can see that he passed away last month or in October.
Sorry.
I've been on peritoneal dialysis for about a half a year. And then he went on hemodialysis for about a half a year, and then said he was done. He couldn't, but we could see his muscle wasting, and and the med management was such a struggle to keep, for him to keep track of what he was supposed to take. And so, that's my story.
Yeah, as a social worker, the balance is so difficult to see. I mean, the description Janelle gives of, watch your potassium, lower your meat, your regular, animal-based meat, and take in plant-based, but then that causes, oh my goodness, the potassium. And, the no orange juice after you're diabetic, after, we have been taught that. It's just kind of swims around, I think, for everyone. And I think the other thing providers can do is encourage this connection with a dietitian, because I've never met a dietitian that doesn't say, stay in touch. Let me know how I can help, because they're really good at this. They understand to help you with balance, and they can listen to your story and perhaps create for you your own balance. I'll mention that Dr. Blomberg also mentioned in chat. So Brittany Blomberg is a family medicine physician. Welcome, and glad to have you, Brittany, Dr. Blomberg. And we hope to see you again, and we hope that you also will reach back to us if we could be of help to share with you some of the other information we've already learned. Maria.
Hi, I'm Maria Rainier. I'm the Senior Director. But I do have one other quick question for you. There's always this little debate about age-based albumin outcomes versus non-age-based. Do you think, right now CMS is not requiring that, especially in the end-stage renal disease world, but do you think that's going to become more prevalent? Because if you look at, the general albumin versus the age-based albumin, sometimes it can be quite different, those outcomes.
Yeah. Well, it's interesting, just albumin in general, the new nutrition guidelines have specifically stated that we cannot use albumin as a marker of nutrition. It just isn't. It's more of a marker of inflammation, outcome, hospitalization, death, those sorts of things. So it's not going away, but it doesn't weigh as heavily on nutrition. I mean, certainly if the albumin's low and we're on top of the patient as far as what they're doing, we can tell you how much nutrition may be contributing, but as a single marker, there's no support for that anymore. I don't know if that answers your question. I know you're asking more about the conversion, I think, between the two. I can't predict that per se, but just albumin in general, what it tells us. It's very serious and we need to pay attention to it, but it's not necessarily nutrition.
Well, I know over the years with survey process, I mean,
oh yeah,
we may have to do some education of our CMS surveyors regarding
exactly
that, because they look at the albumin level and they say, okay, well, what are you doing about this? From a dietary management standpoint.
Well, and what always drove me crazy was they would say, this patient's well nourished because their albumin was 3.9, and I'm like, are you kidding me? They've lost 20 pounds. They, every other marker of nutrition was very poor, but, so it gets back to that single marker. And that was kind of the motivation in these 2020 guidelines to include that, because if this is now the national guideline and acceptance and understanding of a parameter, that usually trickles back to CMS, if that makes sense. So hopefully, but as dietitians, it was a big, because some we cannot treat, if there's underlying inflammation, you can feed a person, you can puff up their fat mass because you're not going to puff up their muscle mass, if they're inflamed. And so yeah, it's been an ongoing battle.
This is Deb again. I just want to have one other comment. I come from a public health background, and the message is we need to teach good nutrition before we have to start watching kidney function.
Absolutely.
I'm on the wellness committee here at our hospital, and it's like, we have to, the plant-based diet is so important. So that's kind of what I'm getting out of this too, is let's prevent people from even getting to nephrology and having to see the dietitian. So
yeah.
Very interesting.
No, it needs to. Oh, sorry, Deb.
No, I was just going to say, this is very interesting. It's above what I need, but very interesting. So thank you.
That's great guidance.
Yeah. Well, please promote it.
Yeah.
Can I just add one little tag? I know, Mary, we need to close out too, but that would be my thing to encourage, as providers. That's why we wanted to focus on this group for this series or these sessions on chronic kidney disease we're trying to prevent dialysis, but even overall for health. What Mary and I are going to do, because I'm not sure how much Medicare covers, but I know some insurances actually do cover nutrition or referrals to registered dietitians for specific conditions. I'm sure CKD is one of those, and it depends upon the insurance. And then we can follow up too on how much Medicare covers, because again, I believe we need to make these referrals even before maybe somebody gets diabetes or hypertension. If we know somebody's pre-diabetic or hypertensive, that's when we need to make those referrals. So Mary and I will follow up on how much coverage there is for some of those things.
So we're looking forward to additional questions. Send them to us via email. We'll get them answered. You may have something you think about afterwards. Again, these sessions are all recorded. They will eventually get out there so that we can share them back with you, so you can either catch up or watch something again. And we really want to thank you, Janelle. It's an excellent presentation, lots of information, very practical. And please, you on the call today, please share it with your colleagues. The slides will be sent to you after the session today. And with that, I wish you a good afternoon.